And without further ado, I think invite you to the next session together with my co-moderator, Professor Christian Brun-Buisson, which will be fully dedicated to the first results of the Mozart project, which has already been introduced by Herman in the previous lecture, standing for the European Network for Mastering Hospital Antimicrobial Resistance and its spread into the community.
While my co-moderator is just coming back in a minute, I might just introduce the symposium, and thank you for staying with us. So, as Herman Goossens just told you, Mozart is part of this big picture of the EU-founded project, and it's been founded under the 6th Framework Program. And it's dealing with control of antimicrobial resistance within healthcare facilities and its spread into the community. So this program is being ongoing since now for 5 years, and actually in its 5th year, so we're nearing the end of the program, and we're lucky enough to have now the first, well, almost first results coming out. This is not the whole story, of course, but it's the preliminary results we will hear about in this session. So we have 5 speakers, and they're dealing with the clinical and biologic work programs that are integrated in this network. So we'll hear about the strategies that have been tested in this program about screening for antimicrobial resistance bacteria, and this program focuses on MRSA, ESBL, VRE, and a little bit of Acinetobacter. We'll hear about what's going on in the ICUs, also about what's going on in the rehabilitation centers, and what can we do with the data gathered in these studies to model the epidemiology of MR in other settings, because, of course, this is only one limited view of what's happening in our hospitals. So each of the speakers has 20 minutes. It's not 25 as written, it's 20 minutes, so that we can have a little discussion as we're a little bit late. So it's my pleasure to call the first speaker, Surbhi Malhotra, who will talk about the screening tests that have been tested in this program.
Thank you very much. Thank you, Christian. And good morning, everyone. Many thanks to the organizers for allowing me and inviting me to present the first results that we've generated as part of the work package on microbiology. So as I was saying, I would be discussing the validation studies that we've been carrying out, and also some external quality assessments with the hospital laboratories participating in the 3 work packages, the clinical work packages. And just a short outline about the state of the art in screening assays for MRSA, vancomycin or glycopeptide-resistant enterococci, MDR Enterobacteriaceae, and also some future trends. So first, the rapid screening tests for MRSA. We validated 2 of the most important and the most popular ones, that's BD Genome MRSA and C5 Gene Expert. They're both real-time PCRs, allowing a definitive identification of MRSA because they target the junction area of, they target the junction area of the SSE-MEC and ORF-X gene in Staph aureus. And the time to result is 1.3 to 1.5 hours. And what we've done in our analysis is that we have two gold standards. In that we've compared both of the tests to a direct culture, which is normally done in most studies, but we've also carried out a pre-enrichment on these cultures and also used that as a true status here. And you can see the differences in results. If you compare genome and expert to a direct culture, you have very high sensitivities. But compared to pre-enriched culture, you see a sharp decrease, especially with expert, you see a sharp decrease in sensitivities, indicating that these tests are not really able to detect single organisms as normally PCRs are theoretically supposed to. But both these tests are not able to do that. And of course, there are some disadvantages of targeting the SSC-MEC-ORF-X region. Because more and more studies are coming out with reports that there are homologues of the ORF-X gene present also in coagulase negative staph. And in fact, this is also what we found in our study, quite some false positive reactions with MR-cons on both the genome and the expert. And of course, there are also reports of former MRSA where the McKay is excised and which are still detected as MRSA positive on both these assays. So to conclude, for our results for the rapid screening tests, they do have a high sensitivity, but they're not able to detect low levels of MRSA as much as culture. They are highly specific, but this might be a disadvantage because you need to know the clinical etiology. There are new MRSA types coming up. There was a recent publication in the Lancet Infectious Diseases on that, and such types would tend to be missed by these assays. They're definitely more expensive. They're definitely quicker than culture, and they're also quite simple, especially the gene expert, which is in fact the first line of point-of-care tests now, and doesn't really require any technical expertise. Of course, it's very heartening to note that MRSA in Europe is decreasing, and in such a situation, such tests are extremely good to perform or extremely useful, because you will see that as the prevalence of MRSA decreases, the negative predictive values of these tests are extremely high at low MRSA prevalences. And this is the situation that we are in now, around 10 to 20% of MRSA within Europe. And this is the situation where these tests can be used with a lot of confidence. So what are the current MRSA screening methods? We've done these external quality assessments in the 3 clinical work packages. 23 hospitals were included, which are now participating in work packages 3, 4, and 5. And it was interesting to note that all these laboratories are using media. In fact, there was just one laboratory that's using media coupled to a molecular test. So definitely chromogenic media are preferred by these 23 hospital laboratories. ChromID from bioMérieux topping the list, followed by BD Diagnostics, Chromegar MRSA, and less number of labs using only conventional media, some also using a combination of conventional and chromogenic media. So we've also evaluated chromogenic media, and this was a study that was published last year in JCM. We've compared both isolates and nasal, groin, and perineal swabs. Isolates have been plated at different concentrations, also non-MRSA. They're mixtures. The swabs, nasal, groin, and perineal swabs, after an overnight enrichment, were plated on 5 different chromogenic media. So these are the most popular ones that are even currently available now. That's the Brilliance MRSA, the ChromID from bioMérieux, MRSA Select from Biorad, Chromegar from Chromegar Microbiology, and BBL Chromegar from BD Diagnostics. So all the samples were randomized, spiral plated, and they were evaluated by 5 different investigators at 2 time points, that is after 24 and 48 hours. And here I'd like to mention that with chromogenic media, it's extremely important to have different investigators also with the variations in experience in a clinical microbiology laboratory, because it's very much visual based. So your perception of color matters a lot. So these 5 investigators ranged from a person who has more than 25 years experience in a microbiology lab to a technical student who had just arrived. So we really looked at the whole range of visual perceptions. And then we picked up 5 putative MRSA colonies and carried out confirmatory tests on this. Of course, looking at the results from a rapid test, we knew that we have to use different gold standards. One gold standard is definitely not enough. Therefore, we used cultures and MICs, as well as a commercial PCR ELISA and an in-house real-time PCR to validate. are true status. These are the results we have for the isolates at different bacterial loads, and what is visible here at 24 and 48 hours is very high sensitivities of brilliance, also of chromide, also at lower MRSA loads. But if you look at the specificities, brilliance performs quite poorly in terms of specificities also at 24 hours. Chromide is also low, but the three other media, MRSA Select, and especially the two chromagars, are extremely good in terms of specificity, and this persists even for 48 hours, which is extremely important that these media the antibiotic selection holds even for 48 hours. Also in terms of sensitivities, both BBL and chromagar are pretty good. At 24 hours you have about 98% sensitivities, reaching 100% after 48 hours of incubation. These are results on the pre-enriched clinical samples. A similar situation. Brilliance, you have high sensitivities, but the specificities tend to be lower. BBL, chromagar, and chromagar are a good balance of sensitivity and specificity, also at 48 hours. So our results from this study were that the two chromagars perform extremely well, irrespective of sample concentration, incubation time, or experience of the investigator. However, all media are very sensitive, and they can detect MRSA at very low levels, that is 10 CFUs per ml. There is a strong inter-reader agreement. There was not much difference in the readings between the 5 investigators, so all the media are pretty user-friendly. So next we've analyzed stool samples on the rapid screening assays available for VRE, and these were, again, the genome and the export. And we took stool samples from patients who have been on renal dialysis, because they are more prone to harbor VRE and have also a long-term colonization of VRE. So what we did here was these stool samples were of course tested based on manufacturer recommendations on genome and gene expert, but we established two kinds of true status. One was based on VRE determination in stool samples on direct culture. So we plated the stool samples on 5 different chromogenic media. We picked up the colonies, identified them by mass spectrometry, and we did a DNA extraction and a PCR sequencing for VAN A and VAN B. But on the other hand, we also did a direct VAN gene detection, which is what these two assays are doing. They do not claim to detect, and they do not detect VRE in samples. They detect simply the VAN A and the VAN B genes, irrespective of where these genes are present. And therefore, they needed a different kind of true status as well, which was a direct VAN gene detection in these tools. So we enrich these tool samples both aerobically and anaerobically, because these genes can also be present in anaerobic bacteria. And this was then subjected to a DNA extraction, which was a really stringent protocol, because some of the bacteria carrying VAN B especially are very difficult to lyse. So we used a protocol, a modified protocol, which is used for Mycobacterium lysis, which has in fact one of the most difficult cell walls to lyse. And after this, we did a direct PCR on the stool samples for VAN A, VAN B, followed by sequencing. So results from this, if we compare the true status on culture, that is presence of VRE, we see that both genome and expert have low sensitivities for VAN A detection. VAN B sensitivities are high, but of course there are only 3 samples, or 3 samples harboring VAN B, harboring enterococci, so this was not really relevant. If you look at the direct PCR-based VAN gene detection, then there are not too many non-enterococci with VAN A, so not much difference in sensitivities here. A large increase in VAN B harboring bacteria. We do not know which bacteria these are, but sensitivities are quite high for both assays for detection of VAN B. Specificities, on the other hand, for VAN B are rather low, and for VAN A are high. And of course, this is reflected in moderate to excellent negative predictive values. We also plated strains in different dilutions and looked at the limits of detection here, and expert always came out better. It was more sensitive at detection of both VAN A and VAN B. So our conclusions, both assays have a reduced specificity for VAN B detection and a reduced sensitivity for VAN A detection. Expert is definitely more sensitive, which might be important, especially in areas where the VRE carriage loads tend to be low. But both assays have moderate to high negative predictive values, and they could be utilized as a rapid screen for screening for gut carriage at the time of patient entry. But of course, you have to do a culture confirmation for VRE carriage after that. So we've also analyzed the chromogenic and selective media that are available for VRE. Again, a similar screen, looking at both isolates and stools, plating different dilutions of both glycopeptide or vancomycin-resistant enterococci and non-glycopeptide-resistant enterococci, as well as stool samples. So here we've analyzed both chromogenic media, chrom-agar and chrom-ID, as well as selective media, which which only give colonies of VRE as black colonies. You cannot differentiate fecalis or faecium here. Again, evaluated by five investigators at 2 different time points. But here the analysis is a little bit different because the 4 media were compared for presence or absence of GRE, so just whether it is present or not. And these 2 media were compared for a colony color differentiation between fecalis and faecium as well. And colonies were identified on standard biochemical testing, and speciation was by PCR. So results for this, so again, it's an aggregated analysis is simply that whether there was a VRE present or not on the 4 media. A penalizing analysis is a comparison between the 2 chromogenic media to show whether there is a good colony color differentiation. And another level of analysis was based on the reader response, so what the reader saw, whether a GRE or a VRE is present or not, and if the colony color correlated to the true status of the sample. But also next, based on the confirmation test. So once we picked out the colonies, whether the colony was actually a GRE or a VRE, that's the aggregated analysis. And if the colony was identified as a blue-colored colony, and it was supposed to be an Enterococcus faecium, whether it was actually an Enterococcus faecium. So these are 2 levels of analysis that we did. So in the aggregated analysis, we see that chrom-agar shows high sensitivities. Specificities of chrom-ID are high. If you look at the penalizing analysis, of course, there is always a decrease in sensitivities because they are not able to, there is a cross-reaction between Enterococcus faecalis and faecium, but specificities of chrom-ID are still extremely high. If you look at the aggregated analysis based on the confirmation test, so if the VRE that is present is actually a VRE, then ECCV comes out to be the best. The selective medium also has high specificities, and actually both these media suffer a lot in terms of sensitivity once these colonies are confirmed for Enterococcus faecalis or faecium. The conclusions from here, both chrom-ID and chrom-agar perform similarly and well, while ECCV is a much cheaper medium, and it also performs as well as the chromogenic agars if you just want to consider presence of VRE or not. And the current screening methods that are being used in Europe, here there are 10 hospitals because only work packages 4 and 5 are working with VRE. So these 10 hospitals, again, they prefer to use media, and they classify Enterococcus agar or ECCV as a chromogenic media, but yeah, actually it's a selective media, and they seem to prefer using this, followed by the Brilliance VRE and the chrom-ID VRE in terms of chromogenic media, and also some labs are using only conventional media. So now going on to MDR Enterobacteriaceae, which is a growing problem in Europe and elsewhere, and we still do not know the optimum control strategy, and screening tends to be rather limited. So here for the rapid screening assays, there's not much available. There's the checkpoints assay and the Identibac. They both have a similar strategy. They're both microarray based, and it's rather logical to have a microarray for detection of multi-drug resistant Enterobacteriaceae because we know that there's a huge array of ESBLs that can be present, and along with that you also have other multi-drug resistances that are present. So if you have a microarray that can pick up to 80 or 90 genes at one time, it's the logical way to go. So the Identibac microarray, we've compared that to an in-house PCR sequencing method for detection of CTXM, SHV, and TEM. Specificities for detection were 100% for all the 3 genes. Sensitivities for detection of TEM were also 100%, but CTXM and SHVs are not detected, are not very, I mean, the probes are not very highly sensitive for detection, and that means that it needs to be modified if it needs to be commercialized and used in a clinical microbiology laboratory. The current screening methods that are being used by the hospitals, by 11 hospitals rather than 10 this time, that are participating in MOSA work packages 4 and 5, most of them are using chromogenic media. Again, this was surprising that a large number is using chromogenic media, chrom-ID, ESBL, and less than half are using conventional media, but mostly without an antibiotic supplement. So we've also done a similar evaluation for ESBL ESBL detection and ESBL detection in Enterobacteriaceae. And here we have compared 4 different chromogenic media and 1 selective media, exactly the similar strategy to what we've done for VRE, comparison at the level of whether it can detect or not an ESBL harboring Enterobacteriaceae, and whether the colony color identification is correct or not. And here we see that Brilliant's ESBL seems to perform the best, both in terms of aggregated analysis, any ESBL harboring Enterobacteriaceae detected or not. This has very high sensitivities and specificities. And if we look at the penalized approach, that whether it gives the right colony color identification, if it says it's an E. coli, it turns out to be an E. coli and not a Klebsiella. It is also showing high sensitivities as compared to the rest of them. Although, of course, there is a decrease if you compare it to the aggregated analysis for Brilliance, and also high specificities. So in our analysis, Brilliance ESBL turned out to be the best media. And our conclusions from this, direct detection from clinical samples is still culture-based. The microarray tests that are currently available cannot be done directly on fecal samples. You have to culture the isolate and do a PCR on the isolate and then put it on a microarray. So all all the time that you can save is the gel electrophoresis, and maybe later on the sequencing time that you might need, so that the microarray can replace. But that's not really a rapid test. You do have a diagnostic delay of 24 hours, whether you use culture or whether you use a microarray-based test. And of course, direct detection is much more complex here because fecal samples are extremely difficult to handle, and there are numerous targets that have to be detected. So for the moment, what we can hope to achieve are solutions where there is an off-board sample prep, in terms of that you have, you're doing a large or a detailed analysis and a detailed sample prep of the fecal sample and then putting it on a molecular diagnostic solution. And this is what we are attempting to do in a recently kicked off project called, or actually it's going to be kicked off in October, called Agnosis. And now, very shortly, some future trends. We've already seen a paradigm shift in diagnostics from the traditional culturing methods to the first level of point-of-care tests, gene export being the archetypal first-generation point-of-care test. But now we need to go on to the integrated point-of-care tests, in keeping in line with the concept of personalized medicine. And having handheld devices, but of course this is an extremely expensive and difficult step. So we've identified areas where we think it's going to be important to implement point-of-care tests. Now in hospitals, we know that diagnostics can influence 60 to 70% of healthcare decisions, but hospitals are not really investing there. The other place where POCTs can improve antibiotic and reduce antibiotic overuse is in the community or in primary care, where acute cough is one of the main reasons why patients are prescribed antibiotics. And if we can have a simple point of care which can differentiate a viral from a bacterial infection, that can result in a massive decrease in antibiotic overuse. A POCT can also enhance surveillance of pathogens. For instance, it could have helped in the H1N1 flu epidemic. It can also help in sepsis. It can definitely help a lot in sepsis because every hour is associated with an increased mortality. And it can not only help in a rapid initiation, but a rapid stopping of the antibiotic, stopping unnecessary use, and facilitating antibiotic stewardship. The other place where a point of care can make a difference is by decreasing the size and cost of antibacterial trials. If there's a point of care that can just screen for patients that have the right pathogen against which this antibiotic is targeted, it can result in a massive decrease in the size and cost of phase 3 clinical trials. So this is the same slide as Herman showed, so I will not go into details on this, just that it's a very, very difficult process, and we are going through it currently, and I can tell you it is indeed bringing a whole lab onto a chip. And one of the major problems that we face is sample preparation. So if you think of sample preparation in a standard microbiology laboratory, you have a lot of time, you have a large sample, you have a lot of frozen reagents, and you have a lot of machines. But an on-chip sample prep, you have to store the reagents on chip, you have microliter volumes, and you probably have a few minutes, actually a few seconds, but you could take a few minutes to carry out sample prep. So we've been struggling with this, and we have been successful in developing an on-chip bacterial lysis and DNA purification protocol. And this is part of an ongoing PERIGE project where we're trying to develop a microfluidic chip for a community-acquired LRTI assay. And as Herman said very rightly, that we do require to join hands with industry to carry this out, and we recently kicked off a project called RAPID for doing the same. These are the members. We have both big pharma, we have microbiologists, clinicians, chemists, physicists, as well as SMEs, especially those which are able to help us with microfluidic solutions. And the overall objective of RAPID, we are planning to develop point-of-care tests for both hospitals and primary care, and we hope to detect bacteria, mycobacteria, fungi, viruses, and host biomarkers, as well as antibiotic resistance genes. So this project is recently kicked off, and let's see where we get to in 5 years. It's coordinated by Janssen Research, and we are the academic coordinators, Professor Goossens especially. So we'll see where we get there. And I'd like to thank the Laboratory of Medical Microbiology, where I work, University of Geneva Hospitals, Stefan and Andy, NMI Poland, Marek Kwiatkowski, and other Mozart and Dobson and Teraj collaborators, and also companies for providing assays for these evaluations. Thank you very much.
Thank you very much. Any questions? So the next few years, what's your prospect about these tests? We're going, let's say, in the next 5 years for the development of the really rapid tests?
Well, it looks very bright for the moment, but we're just beginning, of course.
We're going to stick to the old-fashioned.
Sorry?
We're going to stick to the old-fashioned way?
I think there will be an improvement in what we have now. So we will move towards point-of-care tests. We might not achieve handheld devices in the next 5 years, but at least we will move towards improving sample preparation and, for instance, having maybe an off-board sample prep, which is actually a rather difficult part, but still having microfluidic cartridges for the analysis, for the detection part. That might go easier because there are technologies available for that. But biotechnology is not so advanced as we would have hoped it would be. So biotechnology is lacking a bit behind. So sample prep is lacking a bit behind. So we might have off-board solutions for sample prep, not the complete standalone solution for all diseases.
I'm Dr. Suresh Kumar from India. Is there any hope for NDM1 screening in future?
Is there any hope for India?
NDM1 screening for future.
NDM1 screening. Well, NDM1, of course, NDM1 is already part of the checkpoints array. But as I said, it's not really a rapid screening test yet. And this is what we're trying to develop in the project that we've recently kicked off. What we need is a direct detection from a rectal swab or a stool sample. And I think that would be feasible. That would definitely be feasible because the microarrays are there. NDM is not very difficult in terms of detection versus the other ESBLs. So if it is already part of a microarray for the detection. What we need to do is just speed up the whole process of detection, not only for NDM, but for multi-drug resistant Enterobacteriaceae in general.
Thank you very much. I think we are looking forward to your next presentation, Surbhi, to learn more about these advanced tools that we still very much like to see in the lab or outside of the lab at the bedside.